I'd like to welcome everyone to this evening's program, and I'm very honored to welcome Ashley Purper. Ashley is with a community cancer control specialist with the Rutgers Cancer Institute of New Jersey. As part of their community outreach and engagement team, she is responsible for educating the community on various cancer prevention and screening topics through workshops and other outreach opportunities. Ashley obtained her Bachelor of Science in Biology from Westchester University and began working with the Cancer Institute after obtaining her Master of Public Health degree in 2021. And now I'm going to turn this evening's program over to Ashley. Welcome.
Great. Thank you so much for having me. Well, welcome everyone to our workshop on LGBTQ+ breast and chest health. We are going to be having a discussion really around breast cancer and how to help protect yourselves moving forward. Again, yes, I'm a community cancer control specialist with Rutgers Cancer Institute of New Jersey. And just a quick disclaimer, as always, this information is for educational purposes only. This is not meant to be a substitute for any medical consultation. If you have any specific questions about a specific medical condition or problem, please still consult your medical professional. So here's just a brief overview of what we're going to be talking about a bit tonight. We are going to talk a little bit about the basics of breast cancer, so we all have a base knowledge of what we're really talking about. We're going to talk about the different screening guidelines. We're going to talk about how your diet and lifestyle may play into breast cancer prevention. And then we're going to touch a little bit on genetic counseling and how that can help you moving forward. I know in a lot of the other two workshops we did talk a lot about the LGBTQ+ terminology and concepts. We aren't really going to touch too much on terminology tonight, just because this is a pretty in-depth presentation already, and I didn't want to, bore you if I end up speaking for a long time. So if there's any terms or concepts you're unfamiliar with, please check out one of the previous videos or any of the resources online. And as usual, I like to start all of my workshops with a pre-test. So if you are watching this at a later time, feel free to, pause, write down your answers. So again, all true false statements that we will talk about at the end of the presentation. The first statement, women under 40 years of age do not get breast cancer. Is this true or false? Lesbian and bisexual cisgender women may be at a higher risk for breast cancer. True or false? Obesity is a risk factor for cancer. True or false? And there is no genetic test for breast cancer gene mutations. True or false? Again, we will launch this again at the end, and that's when we will talk about the answers. So first, we are going to talk a little bit about cancer basics in general and breast cancer basics. Really talk a little bit about anatomy, really what cancer is, and then some statistics. So, what is cancer? We hear this term a lot. So in a genetically healthy person that does not have any cancer cells, the cells will grow and divide as needed, your bodily cells. And then when the cells die, when they become old or damaged, and then they get replaced by new cells. With cancer, what happens is these cells begin to divide and replicate and divide really without stopping. They don't have that programmed cell death, and they're not getting replaced. They just keep growing and growing and growing. So basically, with cancer cells, these older damaged cells really survive when they shouldn't. New cells form when they are really not needed to form. And these extra cells, again, just keep dividing and grow into the surrounding tissue, making growths called tumors. So with breast cancer or chest cancer, there are really three main risk factors for developing breast cancer, and that is having breast tissue, having a family history of breast cancer, and the natural aging process. So basically, anyone with breast tissue is at risk for developing breast cancer, and you're at a higher risk if there is a strong family history. Your risk also increases as you age. So first, we are just going to talk a little bit about the anatomy. So this picture all the way on the far right, let's see if my mouse will go all the way over. All the way on the far right, you can see each breast is made up of both lobes and ducts. These lobes lead to smaller lobules, which produce milk, and then the milk travels down the tubes that are called ducts to come out the nipple. Behind the fatty breast tissue is our chest wall, which includes muscles, which is on top of our rib cage. It's really important to understand these different body parts because there are two main types of breast cancer. You have ductal carcinoma, which starts in the tubes that carry the milk from the breast to the nipple. And then you have lobular carcinoma, which starts in the lobules that actually produce the milk. In this picture here on the far left, we see that throughout our whole body, we have what is called the lymphatic system, which is colored in green in this picture. Lymph vessels are a lot like veins, really, but instead of blood, they're carrying a clear fluid. You can see in the middle here that the breast also has these lymph nodes, these that are also colored in green. And it's important to understand that you have these lymph nodes very close to your breast tissue because more often than not, once the breast cancer spreads from the breast, the first area it goes to is the lymph nodes under the armpit here, making the cancer pretty easy to spread throughout the rest of your body. Now, I want to mention this is a bit of a unique discussion. Most current cancer data research really focuses on the binary of men and women. While there are disparities in breast cancer in the LGBTQ+ community, which we will discuss briefly in a few slides, a lot of research is limited due to a lack of SOGI data collection. This sexual orientation gender identity data hasn't routinely been collected in a medical setting until the more recent past. So we're going to review some breast cancer statistics. About 1 in 8 women, most of these statistics mean cisgender women, so those who were assigned female at birth and identify as female, will develop breast cancer in their lifetime, and the risk of cancer increases as the woman ages. For 2021, the American Cancer Society, again, this is a little bit outdated, there hasn't been super current trends, there are about 280,000 new cases of invasive breast cancer, and about 43,000 women will die from breast cancer. On the gray arrow here, you can see that breast cancer is the leading cause of the second leading cause of cancer death in women, with the first being lung cancer. In New Jersey specifically, we are looking at about an estimate of 8,300 new cases and about 1,200 deaths. But there is some good news if we want to think about it that way. There are a lot of advances in early detection with the use of mammograms and some better treatment options. So there are currently about 3.8 million breast cancer survivors living in the US. Now, it's important to note that men have breast tissue as well and are also susceptible to developing breast cancer. It does happen a lot less often than in those assigned female at birth. And male breast cancer makes up only about 1% of all breast cancers. But again, it is important to note that anyone with breast tissue is susceptible to developing breast cancer. But when they say these breast cancer statistics in men, they are again referring to those who were assigned male at birth and who have not undergone any type of hormone therapy. For 2022, the American Cancer Society estimates that for men, there will be about 2,600 new cases of invasive breast cancer, and around 530 men will die from breast cancer. For men, again, cisgender men, the lifetime risk of getting breast cancer is about 1 in 833. Now, I want to mention we do not know really all the exact causes and reasons behind male breast cancer, but some risk factors include, again, getting older, having a genetic mutation like a BRCA1 or BRCA2 gene mutation, a strong family history of breast cancer, any hormone therapy that has estrogen, having previous radiation to their chest, and sometimes there are rare conditions such as Klinefelter syndrome, where males actually have an extra X chromosome, and so their body produces more estrogen. So in Klinefelter syndrome, they actually have 2 X chromosomes and 1 Y chromosome. So again, their body is producing more estrogen. So now I want to talk a little bit about LGBTQ+ disparities in breast cancer. According to the National LGBT Cancer Network, we do not know nearly enough about cancer in the LGBTQ+ community. None of the large national cancer registries and surveys of cancer incidence really collect data about sexual orientation or gender identity. This really leaves lesbian, gay, bisexual, and transgender cancer survivors invisible among the vast wealth of information that these surveys do provide to other groups of people. Other ethnic, geographic, and racial populations are able to use the data gleaned from these statistics to develop prevention and treatment programs dedicating to eliminating these health disparities that they face. They really know how prevalent cancer is in their communities, whereas the LGBTQ plus community really does not have that concrete evidence. A lot of the disparities we see are kind of deduced based on the risk factors we see in the community. But again, that national data collection really is lacking. And again, there is reason to believe that LGBTQ plus people carry a disproportionate cancer burden. There is adequate research to confirm that lesbian, gay, bisexual, and transgender people have a unique cluster of risk factors that would lead them to have both greater cancer incidence and later stage diagnosis. While there is no biological difference that puts LGBTQ plus people at higher risk for cancer, there are many social and other factors that contribute to a higher burden of disease. In regards to breast cancer specifically, lesbian, gay, and bisexual women do have higher rates of diagnosis than their non-LGBT counterparts. And this is because we see a higher rate of breast cancer risk factors for lesbian, gay, and bisexual women. From the previous program, we see that they have increased rates of smoking, increased rates of alcohol consumption. There's oftentimes a lack of biological children, or they're having biological children at later ages, meaning they're less likely to breastfeed. And we have seen that breastfeeding is a cancer risk reduction. There's also higher rates of obesity, which we will talk about a little bit down the road, that obesity is a risk factor for breast cancer. I feel it's important to highlight some racial disparities as well. People do belong to many groups as part of their identity. And so people may belong to one or more marginalized groups and therefore have compounding disparities. For example, someone who is Black and also identifies as a lesbian may be at an even higher risk for developing breast cancer or being diagnosed at a much later stage of disease. In this slide, you can see that there are disparities in breast cancer. In the graph on the left here, we see that white women, which are represented by this top red line, are the racial group most often diagnosed with breast cancer. However, we see in the graph on the right that Black women, which are represented by this top blue line, actually have a higher death rate. So while even though more white women are diagnosed with the disease, more Black women actually die from it. Now, researchers can't pinpoint exact reasons, but possible risk factors could be related to socioeconomic status, lack of access to care, proper education, having a later stage of breast cancer diagnosis, differences in the types of breast cancer tumors. Black women do have more triple negative breast cancers than white women, which are harder to treat. Next, we are going to talk about screening guidelines, screening options, and really the importance of screening. So mainly for today's discussion, we're talking about screening and not diagnosing. Screening is different than diagnosis. We can think of screening as almost prevention. And if anything is found, then the diagnosis takes place. And our focus today, and for many of our talks, is on the screening and prevention portion of cancer. So why is it important to detect early? Well, routine cancer screenings aim to catch the cancer in its earliest stage. The goal of screening is to catch tumors really at this 1 centimeter size or even smaller, and before it spreads to the lymph nodes and other parts of the body. The earlier the cancer is detected, the easier it is to treat, and the patient is more likely to have a better outcome from the treatment. The stage of breast cancer is dependent on the size of the tumor, whether it has spread to the lymph nodes or not, and whether it has spread to other parts of the body or not. Again, this just shows why it is important to detect early. Here we see the 5-year relative survival rates of when a cancer is diagnosed. So if a cancer is diagnosed at a local stage, the cancer has not spread to the lymph nodes, it has not spread to any other part of the body, it's really in that 1 to 2 centimeter size, the 5-year relative survival rate is actually 99%, which is which sounds really great. Then we see, at the regional stage, the cancer cells have spread beyond the breast, but it's really limited to those nearby lymph nodes in the armpit and hasn't spread to other lymph nodes in the body or other organs in the body. There's an 86% 5-year survival rate. Then unfortunately, we see once the cancer has spread throughout the lymph system, it has spread to other parts of the body, it's really metastasized and grown, that the 5-year relative survival rate drops definitively to about 30%. So we really want to catch these cancers as early as possible, which is why routine screening is so important. So on the screen here, we have the screening guidelines from the top 3 main screening sites, research sites. And again, this is for cisgender women, those who were assigned female at birth, identify as women, they're not undergoing any type of transition. We can see that the consensus across these 3 networks really is around the age of 40 is when we start screening. We start with those yearly mammograms. But again, this is for those cisgender women who are at average risk. People who are at average risk are those who don't have a strong family history of breast cancer or other cancers. For those under the age of 40, you really want to talk to your doctor about your breast or chest health and history, really every 1 to 3 years. Later in the presentation, we will talk a little bit more about who should get screened earlier than the recommended age. And I want to note that there are currently no screening guidelines for cisgender men. We did note that male breast cancer is a possibility, but there's no recommended yearly screening for that. That was really just something that you would talk to your doctor about, mention that you may have a known gene mutation if you do, or if your mother, your sister, your grandmother, your aunts, they all have breast cancer, there is a chance that you have a mutated gene, and in which case you would be tested for that. But men don't typically go and get, MRIs and mammograms. But now I do want to talk a little bit about the screening guidelines for some of the gender minorities. So screening guidelines for transgender men, those who were assigned female at birth. So if someone who was assigned female at birth identifies as a man, a transgender man, if they have not had any breast reduction or any mastectomy, the screening guidelines are the same as we saw for cisgender women. Starting at the age of 40, you have the option to start your yearly mammograms. However, if most of the breast tissue has been removed, you may not have enough breast tissue to have a mammogram. In those cases, an MRI might be recommended. There's no real clear consensus on screening if you've had the breast reduction or double mastectomy. And there are some sources that state that taking testosterone can help reduce the risk of developing breast cancer, but it's not fully preventative. Again, anyone with any breast tissue is at risk for breast cancer. And this is really where you'd want to talk to your healthcare provider to determine the risks, especially if there is a strong family history of breast cancer. So now I want to mention the screening guidelines for transgender women, those who were assigned male at birth. So someone who was assigned male at birth does have less exposure to estrogen over their lifetime, which may contribute to a decreased risk of breast cancer. And so breast cancer screening for transgender women is really recommended based on hormone therapy or any estrogen exposure. One thing I do want to mention is that trans women will often have dense breasts, and this can lead to false negatives in mammograms, but it's still important to talk to your doctor and get mammograms if it's recommended for you. The recommendation currently for transgender women is to begin mammography at the age of 50. However, that's only if there's been 5 or more years of feminizing hormone use. So after 5 years of hormone use, you would get a mammogram or other screening, and it is recommended to continue those screenings every 2 years from that initial screening. Again, this is why it's important to really have these conversations with your doctor, let them know when you started taking hormones, how much you take, because that may change your screening guidelines moving forward. And those are both great examples of shared decision-making. And shared decision-making is important in healthcare. Shared decision-making is a process that involves the healthcare provider and patient having a discussion of the pros, cons, and uncertainties of screening. It's not meant to be a one-sided conversation and is based on evidence provided by your individualized case. Studies do show that there is actually less screening when shared decision-making isn't part of your normal healthcare visit. This is especially important if there's a first-degree relative that has or has had breast cancer, or if anyone in your family has had cancer under the age of 45 years old. These tend to be more aggressive, so having that screening discussion with your healthcare provider is even more important. In addition to breast cancer, you want to let your healthcare provider know if there is any ovarian, pancreatic, or metastatic prostate cancer in your family history, because these may be tied to the same genes that can cause breast cancer. You really want to be an advocate for your own health. Now, here is an example that there is a breast cancer risk assessment tool that you can go through. It is recommended to start between the ages of 35 and 85. It will really guide you through some questions to help determine your risk of breast cancer. Again, this is not a replacement for a medical consultation, but it can really help guide that conversation. So let's take a look at what breast changes, chest changes that you may notice that you should really speak to your doctor about. Any lumps or swelling or color changes in the breast, if size or shape changes really seems to come on suddenly, this should also be discussed. If you have any dimpling or pulling, puckering, or redness, again, that seems to come out of nowhere, bring it to your doctor's attention. New pain that doesn't go away, any sudden discharge, don't ignore that. Any itchy, scaly skin or a rash that doesn't seem to go away. Again, make sure to follow up with your doctor because these can all be signs and symptoms of cancer. And this is really where, I want to get on my soapbox a little bit here. You know your body best. This is where you really can advocate for any workups to be done. Really familiarize yourself with how your chest looks and keep note of any changes that may occur. This is important for everyone, regardless of whether you're LGBTQ+, non-LGBTQ+, transgender, cisgender. Really take note of what your chest looks like and just keep an eye on it. They recommend every month to do like a manual self-exam on yourself. I really encourage that everyone does that. Now we're going to talk about some various screening tests. A mammogram is the most common form of breast cancer screening. We recommend this type of screening because it has been shown to reduce cancer deaths in those with breasts between the ages of 50 to 69. A mammogram is really just an X-ray that can help find any abnormal cells or tumors that may be too small for you to feel in a manual breast exam. We think about it, once you have a 1 centimeter tumor, if it's deep inside your breast, you might not be able to feel that, which is why even if you don't note any changes, it's still important to, if you're of age and of certain risk factors, to get these mammograms. While mammography is the gold standard for screening, it does have some limitations, and there are several factors that can actually affect the accuracy. These include breast tissue density, the skill of the radiologist, the size and location of where the tumor is formed, age and weight, sensitivity of breast tissue to hormones, quality of picture. But again, I don't want this to discourage you from seeking this help. It is still very important. We just like everyone to have all of the information, which is again important in self-advocacy. MRIs can also be used for breast screening. It's radiation-free and can be used for those with a high risk factor, strong family history where a mammogram might not be enough. Or as we saw in the guidelines for transgender men, it can be used when there just isn't enough breast tissue for a mammogram. For a mammogram, you have to have enough tissue to place onto the screen. There are some other methods that are being studied, which include different types of breast exams, thermography, which is based on temperature changes in tumors, and tissue sampling. Screening is technically a medical procedure, and there's going to be some risks with any kind of procedure, but in most cases, especially with mammography, the benefits far outweigh the risks. Some of the risks do include pain, bleeding, anxiety, just false negative or false positives. Again, I hear a lot of the reasons that people don't seek mammograms is just the pain of it. I've heard it's extremely uncomfortable. I can imagine it's extremely uncomfortable, but again, those risks of catching a cancer early outweighs the pain you'll be in for the few minutes that you're in there. Now, I also want to highlight that there can be barriers to cancer screening. We are fully aware that some communities experience more barriers than others in seeking cancer screening and prevention and treatment. And we see this especially in the transgender community. For many people, lack of insurance is a huge barrier. I will provide a resource, towards the end, that if you are uninsured or underinsured, you can still get the help that you may need. In the transgender community, and really the overall LGBTQ plus community, there has been a lot of discrimination, and especially from healthcare providers. There's a lot of mistrust there due to mistreatment in the past. And so it's going to take some work on the side of medical providers to really overcome that. We do see discrimination a lot, really, in many minority groups. We see this mistrust, which does lead to people avoiding medical care. If you've had a negative experience, you kind of don't really want to go back and go through that all over again. There can also be anxiety about screening and discussing care when your gender identity doesn't match the sex you were assigned at birth, or it can also be uncomfortable if it goes against any of your cultural norms. I do want to point out that we do see higher rates of uninsured in the Black trans community compared to other groups. So again, lack of insurance is a huge barrier. So in this section, I do want to talk about some lifestyle habits that can be used to control that may help reduce your risk for breast cancer. I want to point out it can help reduce your risk. It will not eliminate your risk. This is really just an empowerment section. The more you know about screening and healthy habits, it really empowers you to take care of yourself moving forward. So, as I mentioned briefly before, obesity is actually a risk factor for developing breast cancer. Also, obesity does lead to diabetes, and diabetes can also increase your risk for breast cancer. So you really want to maintain a healthy weight. Again, obesity increases the risk for breast cancer, especially in postmenopausal women who have not used any hormone replacement therapy. The best way to just keep your weight within a healthy range, you want to, eat lots of fruits and vegetables. You really want to think of filling half of your plate with fruits and vegetables, eating whole grains when possible, as opposed to white grains. Eat healthy low-fat proteins, your chicken, turkey, beans even. Another thing you can do is get more physical activity, exercise a little bit more. When people think of exercise, they tend to associate it with weight loss or maintenance, heart health, which exercise is great for all of these. But exercise may actually help to reduce breast cancer incidence and tumor growth. Exercise reduces sex hormones like estrogen and other growth factors that have been directly linked to breast cancers. And it reduces inflammation, which is also a cause of cancer. Exercise helps to lower high levels of blood insulin. High levels are linked to the development and progression of cancer. Again, this is why diabetes is a risk factor as well. Exercise also improves the immune system. And just by exercising regularly, we're keeping ourselves in a healthier space. And exercising can help prevent obesity, which again helps prevent all of the diseases that are tied to obesity. Exercise doesn't just prevent cancer. People with breast cancer, including high-risk breast cancers, have been shown to have better survival outcomes when they exercise. Now, I don't mean going out and training for a marathon, working out for hours in a gym. If that's your thing, go for it, keep going. General guidelines are about 2.5 to 5 hours of moderate exercise a week, or 1 to 2.5 hours of vigorous activity. You can take a 30-minute walk for 5 days a week, 45 minutes of Zumba 3 times a week. Just to give an example of how effective it can be, there was a study that showed that women who exercised before they were diagnosed with breast cancer and then after their treatment ended were less likely to have a cancer recurrence. While exercise isn't the only thing to help reduce cancer risk and improve outcomes after treatment, it's definitely something that should be, in your healthy lifestyle toolbox. So alcohol intake. So alcohol is actually a carcinogen. A carcinogen is anything that is known to cause cancer. Drinking alcohol can increase your risk of cancers of the mouth, throat, esophagus, larynx, liver, and breast. The more you drink, the higher your risk. And this goes up if you also smoke in concurrence with this. Moderate drinking is okay, but keep in mind that moderate drinking is really 1 drink per day for women and only up to 2 drinks per day for men. And you can't just bank them all in one day. You can't just not drink during the week and then have 7 drinks on Sunday and think you're still fine. That's considered binge drinking. So now we're just going to talk briefly about genetic counseling and how it relates to this topic of breast cancer. So about 5 to 10% of all breast cancer cases are thought to be hereditary, meaning they result directly from a genetic mutation that has been inherited from one of your biological parents. Now, genetic counselors specialize in multiple fields such as prenatal health, pediatric, cardiovascular, neurology, etc. But they can really help guide you in figuring out which further tests may be useful for a person. So if there is a strong link of cancer in your family, speaking to a genetic counselor can then help you figure out if you should get genetic testing. So it's important to discuss with your healthcare provider your family history of cancer and if seeing a genetic counselor is the right choice for you. And when you are getting ready to meet with a genetic counselor, it's important that you are prepared for the visit. It's best to know, if possible, all the people in your family that have been diagnosed with cancer. This includes everyone, cousins, grandparents, great-grandparents, aunts, uncles, and if possible, know their type of cancer and the age they were diagnosed. Because again, if they were diagnosed at an unusually young age, there is a chance it's tied to a genetic mutation. For breast cancer risk, it's especially important to know about your family history. For these cancers, any breast cancer diagnosed before the age of 45, certain Jewish ancestry with a diagnosis of breast, ovarian, pancreatic, or prostate cancer, bilateral breast cancer, ovarian cancer, prostate cancer, pancreatic cancer, male breast cancer. As I mentioned before, male breast cancer usually has a strong tie to a genetic mutation, and those triple negative breast cancers. This isn't just an example of what a genetic testing panel might look like. You can see on the left-hand side, these are the genes they would be testing that have been associated with some type of breast cancer, et cetera. And then on the right side, we can see the cancers that they are directly related to. So this is what your gene testing panel may look like if it's something that is recommended for you to do. So why it's important to understand the risk and have this genetic testing done if it's recommended? Well, the average risk for someone who is a cisgender woman or someone who was assigned female at birth who has not undergone any hormone therapy has a risk of breast cancer that is about 12%, meaning that 1 in 8 people that will be diagnosed, as we mentioned before. But if a person with breasts has the BRCA1 or BRCA2 genetic mutation, their lifetime risk of breast cancer is actually up to 87%. So that means 87 out of 100 women with this BRCA mutation will develop breast cancer. So that's why it's really important to know your family history and if there is a genetic cause for cancer in your family. So again, all of this, if you fall within these screening guidelines, you really should start scheduling your mammograms. If uninsured or underinsured, I will talk about NJ-Seed in a few slides, which helps people who don't have insurance get healthcare screenings. So if you do have insurance, make an appointment with your healthcare provider, get a prescription for a mammogram, and call to schedule the mammogram. And the most important thing is show up. Once it is scheduled, it is important for you to actually go through with the procedure. So just some take-home messages, know your risk, talk to your family, talk to your doctors, get screened, discuss any abnormal breast changes with your doctor, exercise for at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity each week, try your best to maintain a healthy weight, limit your alcohol intake, limit your smoking, really quit smoking if you do smoke. And if you are someone who is able to breastfeed and that is something that is in your future, then make sure you do that. So now I do want to point out that I mentioned I think briefly in this one, but a few times in the other presentations, that LGBTQ plus individuals are less likely to seek preventative care due to, lack of insurance, discrimination, stigma, fear, etc. So here are just a few services in New Jersey that offer primary care and other health services specifically for the LGBTQ plus community. So we have the Proud Gender Center in New Brunswick, the Babs Sipperstein Center in Somerville. I included, again, OutCare here. It is an international directory that if you go on, enter your zip code, it will give you all of the LGBTQ plus affirming providers near you. And this isn't just for primary care, it's for mental health, specialized care, cancer screenings, really any type of healthcare that you may need. Affirming providers will show up near you and you can make your appointments with them. And again, here's just a few other local, state, and national resources. Again, we have PFLAG of Jersey Shore. We have the Pride Center of New Jersey, Garda State Equality. I also want to mention Out in Jersey is a very large community portal, again, that provides people with, almost a directory of various resources for the queer community, again, including primary care offices, but also any other services that you may need. The National LGBT Cancer Network is a great hub of information for those affected by cancer in any way. They aim to improve the lives of LGBT cancer survivors by way of education, training, and advocacy. They also have resources and information for caregivers. Now, here's that resource I mentioned before, NJ Seed. In our state, we have these New Jersey Cancer Education and Early Detection Centers. It is a program run by the Department of Health in collaboration with a lot of local agencies and healthcare systems. The NJ Seed program provides education and outreach within the community about different types of cancer. The program also provides free screening for different types of cancer for those that are unemployed, underinsured, or uninsured, or face other barriers to getting the cancer screenings that they may need. The NJ Seed program currently provides screening for breast, prostate, cervical, and colorectal cancer. There is at least one program in all 21 counties across the state. Some counties do have more. So no matter where you are living, there will be an NJ Seed agency relatively close to you. Their information is here on the screen. I also want to mention another free service that is statewide. It is the Screen NJ Patient Navigation Service. This is a service that will help connect community members to cancer screenings and assist them with any other barriers they may be facing to seeking these screenings. They can help you schedule appointments. They can help you navigate insurance, if there's any language barriers, transportation concerns, education concerns. Again, free service, located all across the state, so no matter where you live. If you have any questions or concerns, they can help guide you through this whole process. And again, they help anyone regardless of insurance status, regardless of citizenship status, as long as the person is located in New Jersey, they can get some help. And that has brought us back to our little test here. Again, if you are watching this at a later time, feel free to pause, compare your answers to see if maybe you learned something new throughout the course of this presentation. So women under 40 years of age do not get breast cancer. This is false. Breast cancer can affect anyone with breast tissue at any age. It is more common the older you get, but that doesn't exclude anyone under the age of 40 from getting breast cancer. Lesbian and bisexual cisgender women may be at a higher risk for breast cancer. This is true. Again, some of the risk factors, the high rates of obesity, high rates of alcohol use, high rates of smoking, they're less likely to have biological children or less likely to breastfeed these biological children. Obesity is a risk factor for breast cancer. This is true. There is no genetic test for breast cancer gene mutations. This is false. There are genetic tests available if it's something that your healthcare provider feels is right for you. That does bring us to the end of tonight's workshop. If you're willing and able, please scan this QR code, fill out a very extremely short evaluation that'll help both myself and the Cancer Institute improve our programs moving forward. And again, thank you for joining me today. And I'll turn it back over to Karen.
Okay, thank you so much, Ashley. This was so informative. And I thank everyone for joining us this evening. And this video will be available on the library's website at justforthehealthofit.org. And it will also be available on YouTube. So I wish everyone a very good evening. And thank you again, Ashley. Have a good night.
Thank you
Bye-bye.
for having me. Good night.
Bye-bye.